Understanding bias in probabilistic analysis in model-based health economic evaluation. This presentation is based on our publication in the European Journal of Health Economics. Author contributions for this article. I thank my co-authors. The outline of this presentation. I will start with the background. In the field of health economics, probabilistic analysis refers to specifying sampling distributions of sample mean as the model input parameters to capture uncertainty around the parameters. Deterministic analysis assigns point estimates to the model input parameters, often represented by the sample mean. The model results of the probabilistic and deterministic analyses are often similar. However, in some cases, probabilistic and deterministic analyses may yield different results. As an example, the network meta-analysis showed that the odds ratio of re-intervention for MoCA versus high ligation surgery was 0.46. 95% confidence interval is 0.01 to 29.92. That is, the point estimate of 0.46 was favoring MoCA with a very wide 95% confidence interval. The odds ratio is assumed to follow log normal distribution, and the expected odds ratio in a probabilistic analysis of these data is 3.7. Thus, drastically different findings of the analysis may be arrived at when the model input in deterministic analysis favored MoCA, while the inputs in probabilistic analyses favored high ligation surgery. The results from probabilistic analyses are inconsistent with what is noted broadly in the literature or reported by many clinicians because the risk of neovascularization and reintervention after surgery is generally higher after surgery than endovenous therapy, such as MoCA. Economic evaluation guidelines from some institutions state that probabilistic analysis provides less biased estimates than a deterministic analysis due to the nonlinear relationship of model inputs and model outputs, and therefore recommend probabilistic analysis to estimate the expected costs and clinical outcomes, using the estimates of mean cost and health outcomes from Monte Carlo simulations. Deterministic analysis uses point estimates which are often best fitted with the observed data, maximum likelihood estimation, and represents the best guess for the model input. When the information that the data contain about the parameter is less certain, the parameter estimates may not be precise and thus have a large standard error. In such circumstances, simulated model inputs used in the probabilistic analysis may generate data which are quite different from the maximum likelihood estimators. The expected values of model inputs in probabilistic analyses may be different than those in deterministic analysis. One such example in varicose vein treatment is mentioned above. Ultimately, probabilistic analysis in which the model inputs may have smaller likelihood to fit the observed data will not necessarily yield more reliable model outputs than deterministic analysis. Simulations from probabilistic analyses may yield more extreme values that can bias the results. For example, the expected value of an exponentially distributed random variable x, years of survival, with a constant rate parameter lambda, mortality rate per person year, is equal to the multiplicative inverse of lambda. When the variance is large, data derived from a study with a small sample size, probabilistic analyses can yield some simulations with small values for lambda and can substantially impact the expected value of x. A deterministic analysis using the point estimate of lambda may avoid this problem. Thus, a probabilistic model may result in larger bias in model outputs than the deterministic model. We aim to understand potential bias in probabilistic and deterministic analysis through simulations. Given that probabilistic analysis and deterministic analysis are generally associated with similar results when parameter uncertainty is small, We mainly discuss the bias related to the two types of analyses when the variance of parameter is relatively large, the sample size of 100 for each hypothetical trial, and the risk of events are moderate, 0.1 or greater. We further explored the impact of bias in probabilistic and deterministic analysis according to sample size, 301,000 patients in each hypothetical trial. Simulation Study 1 evaluates biases associated with using risk ratio as the effect measure in probabilistic versus deterministic analysis. Measures of comparative clinical effectiveness are often expressed on a relative scale, such as a risk ratio, odds ratio, or hazard ratio. These measures are generally defined in log normal distributions in a probabilistic analysis. Here is the formula of the expected value for the log normal distribution data. We compared the bias of risk ratio in probabilistic versus deterministic analysis. The notations of this simulation study are shown in Table 1. We drew density plots of bias of risk ratios for probabilistic and deterministic analyses in scenarios 1, 2, and 3. With an increase the sample size from 100 to 1000, the distributions of bias were subject to normal distributions in both probabilistic and deterministic analyses. This table shows the results of Simulation Study 1. Both probabilistic and deterministic analyses produced biased estimates for the true risk ratio. The magnitude of bias and mean squared error in both analyses markedly decreased with a larger number of patients in each hypothetical trial. The biases and mean squared errors in the probabilistic analyses were greater in all scenarios. The proportion of absolute bias in the probabilistic analysis greater than that in the deterministic analysis in scenarios with sample sizes of 100, 300 and 1000 were 0.554, 0.526 and 0.519, respectively. Simulation Study 2 evaluates biases of mean cost estimates using smearing estimator in both types of analyses. We generated log normal distribution cost data for the regression analysis. We chose the values of coefficients for the model and the distributions of predictors based on a published cost study of treatments for prostate cancer. We assigned a contaminated normal distribution for the error of regression model. A contaminated normal distribution is a specific case of a two-component mixture distribution in which both components are normally distributed with a common mean. We simulated 100,000 hypothetical trials in all three scenarios. For each hypothetical trial, we simulated 100 patients. We applied the smearing estimator to the median costs from the model to calculate the mean cost. We summarized the data from 100,000 repetitions in three scenarios and evaluated the performance in Table 3. Three scenarios showed that the mean cost estimates obtained from the deterministic analysis had smaller biased and mean squared errors than the probabilistic analysis in four groups. Overall, the magnitude of bias increases with the larger true estimates, when the number of patients per trial remains the same. When defining a larger error of regression model, the bias in probabilistic analysis increased considerably while the impact on the deterministic analysis was smaller. Simulation Study 3 compares bias in expected life years in a two-state Markov model in probabilistic versus deterministic analysis. We consider a simple Markov model with two health states, alive and dead. Conceptually, this two-state Markov model is approximately equivalent to an exponential survival model with a constant hazard function, but the survival time of an individual is discrete with a fixed interval, the Markov cycle. Here, we briefly introduce the process of generating data in each scenario. We present the results of the simulations 3 in Table 4. We provided a summary of our findings. The biased and mean squared errors of deterministic analysis were smaller than that in the probabilistic analysis in 3 scenarios. When the cohort size was small, n equals 100 in scenario 1, the bias of life years in the probabilistic analysis was much greater than the deterministic analysis, 3.19 versus 1.16. However, when the cohort size was large, n equals 1000 in scenario 3, the biases were much smaller in both approaches, probabilistic 0.19 and deterministic 0.09. In economic evaluation, both the costs and quality adjusted life years, CALI, are linked to life years. Thus, it is expected that the biases of costs and CALI in probabilistic analysis would also be greater than in the deterministic analysis if we extend the above example to CALI and costs. Our simulation considered a single group. When comparing the cost effectiveness of 2 groups, the incremental cost, incremental effectiveness, incremental cost effectiveness ratio, or incremental net monetary benefit, it becomes more complex. There are more parameters involved in the estimation process, and there are different approaches to model the efficacy of the intervention. It would be case by case which analysis is associated with less bias. We may caution the application of probabilistic analysis under some conditions when deterministic analysis may be more appropriate for these cases. For instance, when the key model parameters have wide, asymmetric confidence intervals, such as odds ratios of clinical effects from network meta-analysis. For another instance, when the variance of a model parameter is large, such as parameter estimates based on data from a small sample size. Here, simulations from probabilistic analyses may yield extreme values that tend to bias the results of some nonlinear models and may not be meaningful. Deterministic analysis can avoid extreme values that probabilistic analysis may encounter and may provide a less biased estimate. We conclude that there is no definitive answer on which analytical approach, probabilistic or deterministic, is associated with a less biased estimate in nonlinear models. Health economists should consider the bias of probabilistic analysis and select the most suitable approach for their analyses. Here is the timeline of this article. Thank you.